As today's session promises to shed light on the critical aspects of maternal and fetal health, a topic that resonates deeply with all of us as healthcare providers. And the interplay between liver and pregnancy outcome is also critical. So our next speaker is a highly accomplished expert with profound insights into managing medical challenges. It is my pleasure to invite Dr. Aleina Badshah, who will be speaking on an equally important topic, liver diseases and pregnancy. So please join me in welcoming Dr. Aleina Badshah. And it would be our request please wind up in the fixed time, as our participants and our guests will have to leave for the Friday's prayer. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much for your introduction and thank you for inviting for this talk. I know we are short on time, so I have made the presentation such that I will be discussing the practical aspects rather than the theoretical, because I believe you all can do self-directed learning as well. So the topic is hepatic hurdles, navigating liver disease in pregnancy for safe maternal and fetal health. Now there are many diseases that occur in pregnancy. Some of them are specific for pregnancy, and then there are some other diseases that occur outside pregnancy as well, but they have different implications when they occur in the pregnant female. So I'll be discussing all of them, but not the huge list that you can see over here. So we've got viral hepatitis that occurs outside pregnancy as well, but if it occurs in a pregnant patient, be that hepatitis A, E, B, D, or C, it is going to give different implications, and the list goes on. So we'll start off with viral hepatitis in pregnancy, hepatitis A. Now, if a pregnant female contracts hepatitis A, that's not much of a critical condition. Hepatitis A is going to complete its duration, and all we need to do is to provide supportive care to the patient and watch out for any complications, though fulminant hepatic failure is a very rare complication of hepatitis A in pregnancy. Causal relationship has been noticed between hepatitis A virus and preterm labor, especially if infection occurs in the second or third trimesters. So if it occurs in the first trimester, you need to keep the patient under observation as an outpatient, but if it occurs in the second or the third trimesters, you need to be a little more cautious. Now this is the viral infection that we all dread when it occurs in pregnancy, especially in the third trimester with genotype 1. Now this is associated with severe infection, and it can lead to fulminant hepatic failure and maternal death. Now in pregnancy, the risk can increase up to 25% mortality. You all are working in medical wards, and you might have seen patients coming to medical wards admitted at a relatively stable condition, and then they can deteriorate anytime. And we have even seen patients delivering IUD babies in medical wards, and then we have to keep liaison with the gynecology and obstetrics department as well. So if a patient contracts hepatitis E in pregnancy and the patient appears relatively stable, do keep it in mind that this might just be the tip of the glacier, or the volcano can erupt anytime. So you have to be very careful with these patients. Now, why is hepatitis E virus so dreadful or dreaded in pregnancy? Because there's an interplay of hormonal and immunological changes along with a high viral load of HEV. As you know, that the levels of progesterone, estrogen, and human chorionic gonadotropin, they increase tremendously during pregnancy because of the hormonal effects that pregnancy has. And apart from that, the pregnant female has to keep the foreign body, the fetus, as a result of which the immunity is compromised. Now then, there are certain viruses that if the immune system is compromised, these viruses start replicating. Hepatitis E virus is one of them, and so is hepatitis B. So there is increased replication of hepatitis E virus, and the high viral load alongside the reduced immunity and the interplay of hormonal changes renders the woman more vulnerable. Now, what about breastfeeding? If a patient has delivered and she's hepatitis E virus positive, what will she do with that? Gone are the days when we all would say that breastfeeding should be done by all mothers if they are diabetic, if they are having tuberculosis, if they are having HIV, if they are having hepatitis B or C. At that time, we would always say that we are living in a very low socioeconomic stratum country, and our patients the babies might be prone to many other infections if they do not receive the passive immunity that they get through breastfeeding. But now the guidelines have changed and they are individually tailored, because these conditions, mothers who are having these conditions, they may transmit these infections to the babies whom they feed. So you cannot keep a strict criteria or follow a strict guideline. The guideline has to be individually tailored. Same occurs in hepatitis E positive mothers. If the hepatitis E positive mother who is breastfeeding is having HEV antibodies positive, the PCR is positive, but the load is low, then yes, she can breastfeed. But if this mother has a high viral load, then she should not breastfeed because these same antibodies and the same virus is going to be released into the colostrum. So you have to look at the patient and then decide accordingly whether she needs to breastfeed or not. And this is basically the crux of this slide. Feeding formula can then be advised as there is a possibility of transmission from infected breast milk or lesions on the nipple through suckling. Another important thing is whether you need to treat these patients or not. If a patient has high viral load of hepatitis E, they can receive ribavirin to reduce the load. One other important point over here is that in our wards, what we do is that we only send the hepatitis E viral serology. And if the IgM antibodies are positive, we stop there and we just diagnose the patient as having acute hepatitis E. But you all should remember that you do need to send PCR as well for these patients because the viral load, the exact viral load is also very important, and that is going to guide you whether this patient needs admission, can be treated on outpatient basis, or what to counsel her about breastfeeding. Viral hepatitis in pregnancy, hepatitis B. Hepatitis B needs to be differentiated from other viruses because, again, if it is presented as an acute viral hepatitis B in pregnancy, it can cause fulminant hepatic failure, so you have to be careful. If a patient is having chronic hepatitis B and she becomes pregnant, then that is going to have another scenario. Gestational diabetes mellitus, antepartum hemorrhage, and preterm delivery. These are the three conditions that are more common in patients who are having chronic hepatitis B infection. Hepatitis B can be transmitted from the mother to the baby during delivery, and again, the mode of delivery doesn't matter at all. It can be transmitted through normal vaginal delivery, and it can be transmitted through a cesarean section as well. All babies that are born to hepatitis B positive mothers need to be vaccinated. The vaccinations should start immediately within 12 hours after birth. As we've been hearing in the previous slides as well, it's all about time. So time is very important. If the vaccination and the immunoglobulin therapy starts before 12 hours, within 12 hours of delivery, that's going to have better outcome. Again, I would say if now you have to look at the patient, how is the viral load of this patient? So if needed, you can even give accelerated vaccination to the newborn. 016 was a duration of vaccination that would be followed when we were house officers. Now we've got different vaccination regimes. You can follow the 013 and the 012 as well, depending on the condition of the baby and the viral load of the mother and whether she was having chronic hepatitis B, acute hepatitis B, or whether it was fulminant hepatic failure. So by 016, I mean कि पहले हम 0 पे देते हैं vaccination, फिर 1 महीने बाद और फिर 5 महीने बाद. But that's not necessary. If you deem appropriate and you need the baby to be developing antibody titers quicker than the usual, you can give them at a comparatively quicker pace by following the 013 and 012 regime. Now, whether to treat or not the hepatitis B positive mother. Again, EASL, APOSL, AASLD, and so many other guidelines have given it all differently. When you talk about pregnancy, the guidelines may be very elaborate when it is about the non-pregnant female or male. But when it comes to pregnancy, the guidelines are not very clear. So I've been through the American College of Obstetrics and Gynecology guidelines, and I've been through all the different guidelines before I could prepare this slide, that there has been experience or experimentation with lamivudine, entecavir, talbivudine, adifovir, tenofovir, interferon. Although the era of interferon is gone, but when we talk about pregnancy, you can still give it in pregnancy. And then pegylated interferon. You can see the categories as well, that out of these, talbivudine and tenofovir are pregnancy category B. The others are category C. So B is comparatively safe. Talbivudine is not usually available in Pakistan, so we can keep tenofovir in mind. And because of the excessive and the prolonged experimentation and experience that lamivudine and consultants have gained between each other, because this was the drug that we would be using in patients when we were final year MBBS students or house officers. Now the newer lot might not be even aware that this was once used. The newer lot might not be even aware that these were the drugs that we've been using and prescribing. But anyhow, although this has been classified as category C, but the results with lamivudine have been tremendous as far as the pregnant female who is hepatitis B positive is concerned. So this is one drug that can be used, and tenofovir is the other drug that can be used. Then, which trimesters to start the drug in? Usually, guidelines say that it's better to start after 28 weeks of pregnancy, but you can start it before 28 weeks of pregnancy as well. And the risk of teratogenicity, whether it is started in the first or second trimester, or whether it is started in the third trimester, are almost the same. Hepatitis D is not very common. It can only occur if there is a previous hepatitis B infection occurring, and then this will be coexistent. But if a chronic hepatitis B pregnant patient contracts hepatitis D during pregnancy, the progression to cirrhosis is going to be rapid. As far as hepatitis C is concerned, all you can do is just to keep the patient under strict observation and check her liver function tests and any conversion to a more sinister stage. But the directly acting antiviral therapy that is being used these days, that is not currently licensed for treatment in HCV in pregnancy. Now, this I have already discussed. I will just talk about herpes simplex virus over here, that although it doesn't have anything directly to do with hepatology, but if a pregnant patient contracts herpes simplex virus, she is at a very high risk of developing acute liver failure. So these patients need systemic antiviral therapy in the form of acyclovir, depending upon her condition, either orally or parenterally. Now, a very other important condition, patients do come to us and then they have to keep on switching between gynae department and medical department, intrahepatic cholestasis of pregnancy. Now, intrahepatic cholestasis of pregnancy is the most common liver disease that is pertinent and that occurs in pregnancy. More common in second and third trimesters. It is associated with severe pruritus. I do not know why pruritus is not coming out, lekin likha hua tha maine waise. Why does it occur? There is a defect involving the excretion of bile salts. The bile salts are not excreted into the bile, as a result of which there is backlog and the bile acids are released into the circulation. These bile acids accumulate in the skin, leading to severe pruritus. Now, there is no relation between pruritus and the concentration of bile acids in the blood. The concentration of bile acids might be low, but the patient might be very symptomatic. And the concentration of bile acids might be very high, but the patient might not be that pruritic. So you do not take that patient critically or seriously, jisko pruritus zyada ho. Again, that means that you have to send the bile acid and bile salt levels for these patients. Okay? At times, we are a little dodged by the more symptomatic patient, but you also have to look at their laboratory values. So it shows over here that it is at this level that this process is not occurring properly, and as a result of which the bile salts are not being released into the circulation. They keep on accumulating over here. They are re-released into the circulation, and then they accumulate in the skin and lead to pruritus. Now, intrahepatic cholestasis of pregnancy is related to estrogen as well. The concentration of estrogen rises in pregnancy, and those people who are at more genetically more tuned to it, the estrogen levels are going to cause cholestasis in them. Now, again comes a question that those patients who are having intrahepatic cholestasis of pregnancy, they should be guided that they should avoid estrogen-containing contraceptive pills in future, because it means that they are at more risk of developing intrahepatic cholestasis in subsequent pregnancies. So they should avoid estrogen-containing contraceptive pills that are going to make them further prone to intrahepatic cholestasis of pregnancy in subsequent pregnancies. One other thing that you should keep in mind, a pregnant female who is, suppose, pregnant for the first or the second time, or those with singleton pregnancies, they might be at lesser risk as compared to those who are multigravida, who have multiple pregnancies, because the multiple pregnancies are going to increase their estrogen levels and then make them more susceptible to intrahepatic cholestasis of pregnancy. This is a very important slide. How do we diagnose intrahepatic cholestasis of pregnancy? When the concentration of the total bile acid is more than 19 micromole per liter. Risk of stillbirth only increases when the concentration rises to 100 micromole. I'll be just taking 5 more minutes. Zero maine dekh liya hai. So the risk of stillbirth rises when the levels increase from 100 from up to 100 micromole per liter. Now, between levels of 19 to 39, you should keep it in mind that the patient is at risk of stillbirth. So at 40 weeks of gestation, if the patient hasn't delivered spontaneously or naturally, you should plan the birth by 40 weeks. If the bile acids range between 40 to 99 micromole per liter, the patient is at risk of stillbirth at a little earlier gestation time. So you should plan it at 38 to 39 weeks if the patient hasn't delivered spontaneously. And if the level of bile acids is more than 100 micromole per liter, then the patient is at risk of stillbirth even more earlier. So you should plan it between 35 to 36 weeks of gestation. जो भी drug हम देंगे इसमें, that is not very efficacious, that is just for symptomatic relief, be that antihistamines, be that emollients. As far as ursodeoxycholic acid is concerned, there are different guidelines and different recommendations. Some guidelines say that if you give it in high doses, it might improve the patient symptomatically. It might even reduce the bile acid secretion and it might improve the levels. But other guidelines say that ursodeoxycholic acid is only for symptomatic improvement. It doesn't have much to do as far as the progression of the disease is concerned. Another very important condition, acute fatty liver of pregnancy. Now, why does this occur? Should I go ahead or stop? Kya karoon? Hi ji. Acute fatty liver of pregnancy. Actually, there are so many diseases occurring in pregnancy and that are all related to liver. So that is what I was telling them, कि ये बहुत ज़्यादा topics हैं एक topic में for 15 minutes. Acute fatty liver of pregnancy, why does it occur? When there is no conversion of acyl-CoA to 2-acyl-CoA and 3-keto-acyl-CoA is not being produced from 3-hydroxy-acyl-CoA. The levels of 3-hydroxy-acyl-CoA, which is a long-chain fatty acid, and the levels of acyl-CoA, which is a medium-chain fatty acid, these increase in the blood, and if they increase in the blood, they are going to cause lipotoxic metabolic intermediates, reactive oxygen species, jiska matlab hai free radical injury, inflammatory pathways, and apoptosis. So this is a very, very fatal condition. If it occurs in pregnancy, bakiyon mein to hum phir bhi treatment options dete hain. We try to wait for the viability of the fetus, but iska ek hi ilaj hai, and that is delivery. तो इसमें आपने और कोई किसी intermediaries के बारे में नहीं सोचना, otherwise you will lose both the baby and the mother. बाकी इसकी laboratory investigations आप खुद भी पढ़ सकते हैं. I'll move on to the next, HELLP syndrome, another very important condition which is hemolysis, elevated liver enzymes, and low platelet count. So HELLP syndrome is characterized by its characteristic peripheral blood smear, जिसमें hemolysis की वजह से the LDH levels would be high, aspartate aminotransferase levels would be high, and the platelet count would be less than 100,000. Then you can do some other complementary investigations, जिसमें coagulation profile and renal function tests are very important. And this is the management. If the patient is symptomatic, you have to manage. Otherwise, if the patient is stable, you have to keep the patient under observation. But do keep it in mind that this patient can proceed to fulminant hepatic failure. So you should have already had a word with the intensive care, and you should have the vitamin K and the fresh frozen plasma ready for such patients. Another important condition जो कि आप लोगों ने देखी होगी, but you do not know that it is different from HELLP syndrome, is the atypical hemolytic uremic syndrome that occurs in the postpartum period. If a patient is HELLP syndrome, she is going to improve within 72 hours postpartum. But if the patient does not improve within 72 hours postpartum and progresses to severe kidney failure, often necessitating dialysis or complement inhibition, then this is not HELLP syndrome, this is acute atypical hemolytic uremic syndrome. So ये post delivery अगर patient नहीं improve हो रही, do consider atypical hemolytic uremic syndrome. Then there are certain other conditions like hyperemesis gravidarum that has implications on the liver. Cirrhosis is a very important topic. If a pregnant cirrhotic patient deteriorates, what are you going to do with this patient? Because of the pressure of the pregnant, the gravid uterus on this patient, she is at risk of hematemesis. There is even a high risk of liver rupture, and there are so many other things that I wanted to discuss with you people, but because of the shortage of time, I won't go into their detail, लेकिन मैं ये share कर लूँगी आप लोगों के साथ. And then a very other important topic, liver transplantation in pregnancy. If a patient has had liver transplantation, after 6 weeks of transplantation, fertility returns. So you should be very careful with these patients. almost 90% of female recipients start having their regular periods 1 year after the liver transplant. Cirrhosis में तो cycle नहीं चल रहा होता ना, because there is hormone imbalance. So इस time में a woman should wait at least for 1 year, preferably 2 years, ताकि transplant को थोड़ा time मिल जाए before the patient again gets pregnant. And if conception occurs in the first year after a transplantation, there is a high risk of prematurity and graft rejection. और ये आप देख लें कि mean transplant to pregnancy interval of 4.07 years seems appropriate, because by that time the patient has taken enough of immunosuppressive therapy and the body has also accepted the graft by 4 years. If a patient becomes pregnant after liver transplantation, immunosuppressive therapy must not stop. The patient should be receiving glucocorticoids, tacrolimus or cyclosporin, and azathioprine, considered safe in this scenario, but mycophenolate and protein kinase inhibitors are contraindicated. So with this, I thank you all for your patient listening. Thank you very much.